Then the condition of the fangs also matter, because if the fang is intact, you know that there will be more effective venom delivery. Then, but if the fangs are broken or damaged, you have more tissue damage. And of course, the pathogen that is in the mouth of the snake, because they harbor bacteria, both anaerobic and aerobic. Now, like I said before, the clinical manifestations, it could be neurotoxic, hemotoxic. And for neurotoxicity, you'll be seeing things like ptosis. Ptosis is like the upper eyelid will droop and cover the eye, and the person will not have any control over it, okay? So there'll be numbness in the limbs and tongue. They all point towards neurotoxicity. Then hemotoxicity is characterized by, could be local, you could see the local effects of hemotoxicity, you could see the systemic effects. The local effects include, you see the fang mark, that's the fangs of the venomous snake on the particular part of the body that was bitten. You see redness, ecchymosis. You could even see dry gangrene, okay, depending on how length of time the bite occurred. Now, the systemic effects include nausea, vomiting, hypotension. You could have hemoglobinuria, which could lead to renal failure. Then cytotoxicity is another clinical manifestation. It also depends on the species of venomous snake that beats the individual, and is usually marked by pain and progressive swelling. Of course, blistering too, like bulle, as if the person had a burn injury, hot water scald or whatever at that area. You see bulle, you see bruising, you see enlargement of the lymph nodes, because actually the venom of snakes is usually transported through the body via the lymphatic system. So the lymph nodes at that draining site could be enlarged. Okay. Now, usually the venom of the carpet viper is both hemotoxic and cytotoxic. Now, there are six clinical syndromes for envenoming. Okay, and they include syndrome 1 is marked. In syndrome 1, you see marked local swelling with coagulated blood. Okay, but in syndrome 2, you see local swelling, but there will not be coagulated blood. The blood will be incoagulable. And of course, there may be systemic bleeding. In syndrome 3, usually characterized by progressive paralysis, that's neurotoxicity. Then syndrome 4 is characterized by mild swelling alone. Syndrome 5 by mild or negligible swelling with incoagulable blood. And then, of course, syndrome 5 is associated with marked local swelling and then neurotoxicity. First aid. Okay, so this is the clinical aspect, which is an aspect that everybody on the face of this earth, every human being should have an idea of what to do at this point in time. Now, the first thing is to move the patient from the site of the accident. But I'll say, in moving the patient, you have to be careful, because the snake that bit might still be around, so that the person doesn't get a second bite from the same snake. Okay, so reassure the patient, immobilize the patient or the affected limb, remove tight and restrictive clothing and accessories. No tourniquet. Now, this is a point where is a bone of contention, and a lot of people get it wrong. Some people will say, tourniquet, it's not so that there won't be a spread of the venom through the system. But WHO recommends no tourniquet. But I'll be telling you, there are cases where you may need to have tourniquet. Okay? Now, tourniquet, you wouldn't want a tourniquet because tourniquet increases risk of gangrene. It increases the risk of fibrinolysis, because particularly in snakes that are hemotoxic, have their venom that are hemotoxic. If you have such a snake bite an individual, usually it goes to the coagulation pathway to elicit fibrin formation. And once fibrin is formed, because the body already has a fibrinolytic system, which is made up of the plasminogen and plasmin system, plasmin will be released to degrade the fibrin. Okay, so the degradation of fibrin takes place, and once fibrin is being degraded, there will be bleeding because the clot is no longer there. Okay, so if a patient has or someone is bitten by a snake that is hemotoxic, and you apply a tourniquet, you are just trying to the only thing that will be doing is that you'll be concentrating the venom at that area, and you will have more damage in that place by you're trying to prevent it from moving around the whole system, but you're causing more local damage at that point in time. But there are some snakes that you may need to, tourniquet may apply. But of course, you may not like the elapids, which is the cobra. They are usually neurotoxic, so you wouldn't want the venom to spread too fast and cause respiratory collapse. But in doing that, you have to be sure actually that the snake that bites is one that is neurotoxic, which you may not know. So it's usually advocated that no tourniquet is, you don't use tourniquet. Now, do not cut, suck, or apply ice, and of course, report immediately to the hospital. Now, when patients present to the hospital, what happens? They're usually assessed based on the ABC criteria, which A stands for airway, B breathing, and C circulation. Sometimes this doesn't really follow the order. For instance, if a patient is already has probably cardiac arrest, of course you start with the C first, which is your compressions or more like your circulation, okay? So you check the airway to be sure that the airway is patent and okay, the breathing, how many cycles per minute is the patient doing, is there need for respiratory backup in the form of oxygen or even intubation, particularly for the neurotoxic venomous snakes that have neurotoxins. Okay, so the history of time and place of bite is very important. You take the history, the time of the bite, the place that it was bitten, the first aid that was applied, and then the progression of the symptoms. These are also considered. Then physical examination to check for bleeding, the fang marks, and of course to look out for other things like swelling. Then you look out for neurotoxicity, like I said, paralysis, because if there's paralysis and the diaphragm is paralyzed, accessory muscles are paralyzed, the patient won't be able to breathe on his or her own. So that's where you will need to, the intubation will be required so that the ventilator will take over for the breathing. Then, of course, the vital signs are important, like your blood pressure, your respiratory rate, your SpO2, and the temperature and all that. Then investigations. Some investigations are vital. Okay, the first one is what you call the 20-minute whole blood clotting test. Okay, in the next slide, we'll explain what that is all about. Then the next one is the full blood count. Why would you need a full blood count? Full blood count, you want it because it will show you the total white cell count and also show you the neutrophils, the lymphocytes, and that's the differentials. Okay, so in snake bite, neutrophilic leukocytosis, that's when the neutrophils are high, it signifies systemic envenomation. Of course, the clotting profile you will need because the hemotoxic type of venoms, they will cause clotting derangement, and then the patient will be bleeding. The site of the bite will be, you have bleeding at that site. The urinalysis will give you an idea of if there's a hematuria, hemoglobinuria, all of which can lead to acute renal failure. Then the EUCR, that's electrolyte, urea, and creatinine, is for you to check for the kidney function. Of course, you do a liver function test to be sure it's okay. Then the enzyme-linked immunosorbent assay. Now, this particular test is really very expensive. It's not freely available. We may not really have it here available in a setting for this call. Now, but it's usually based on the antigens in the venom. It helps to identify the particular species that bit the patient, but I don't think, I'm not sure we really have it so much here in this part of the world. Okay. So now this one is I'll explain about the 20-minute whole blood clotting test for diagnosis of coagulopathy. Now, what you will need a 2 ml syringe, you will need a test bottle. That test bottle should be clean. It shouldn't have been washed previously with detergent, or it shouldn't contain any agent inside it. The in vitro anticoagulant, it should not contain it. It should just be clean and empty and dry. Now you have your tourniquet, you have your timer, your gloves, and of course your disposable, where you're going to dispose the syringes. Now the tourniquet is applied and patient's blood is withdrawn like 2 ml, and the 2 ml is put inside the test bottle and it's timed. After 20 minutes, it is checked. It's not supposed to be shaken. You tilt it at about 45 degrees, and if the blood has clotted, that means it's negative. There's no venomous envenomation, okay? But if it's still liquid, that shows that there's envenomation. But this particular type of test really helps you to determine the hemotoxic type of snake venom. Okay, it may not really work for the cobra, which is an elapid, which they are usually neurotoxic. So it usually works more for the viper, which contains hemotoxic venom. Okay, so it may not really work for the cobra. So now, diagnosis is usually made after reviewing a patient's history and physical examination and then doing the 20-minute whole blood clotting test for coagulopathy. After that, you also do a neurological assessment to assess the respiratory muscles because, like we said before, the type of venom, it could be hemotoxic, neurotoxic, cardiotoxic, nephrotoxic, or even cytotoxic and myotoxic. Now, clinical management. Snake bite is a medical emergency, so it's very important. Speed is crucial. Getting the patient to a center where he can receive or she can receive care based on the anti-snake venom. Okay, so the anti-venom is very, very important. It's indicated in all cases of systemic and severe local envenomation. And the dose, usually the dose is not dependent on weight or age. So both children and adults receive the same dose. And the reason being that when anybody is bitten, it doesn't say, okay, this is a child, the snake will say, okay, this is a child, I'm going to bite small. No, it's the same. So the volume of venom that goes in is basically the same. So the dose is the same for both adults and children. Now, in the clinical management, like we said before, there will be rapid clinical assessment and, of course, resuscitation. Very important. If there's need for cardiopulmonary resuscitation, it will be instituted. Patient will be resuscitated based on the vitals that are showing. If there's shock, of course, your regular normal saline to help push up the BP so that the patient is made stable before we can, while we're trying to institute, to diagnose and then see if we can institute use of the anti-snake venom. Okay. Now, administration of the anti-venoms, we'll look at it very closely. Now, this anti-snake venom is the only effective antidote for snake bite. It could be monovalent or monospecific, that where it's for just a particular species of snake, or it could be polyvalent for maybe 3 or 4 different species of snake. What is usually available most times in our climb is the polyvalent one, okay? So the anti-venom usually neutralizes a fixed amount of venom. Usually this snake anti-venom is scarce, is expensive, and it has potential serious side effects. So it must really be indicated before it is used. It should not be used if it's not indicated. Like we said, remember we said that some bites by venomous snakes, they are dry bites. That means they didn't put in any venom in the person. Now, anti-venom is not always necessary, like I said before. And so it could be non-venomous. If the snake is non-venomous, you don't need the anti-snake venom. It's just basically you manage based on the signs and the symptoms that have been shown, that the patient is showing. And if it's a dry bite too, you wouldn't need it because this anti-snake venom has a lot of side effects. Now, the anti-snake venom, they are most effective when given intravenously. And first of all, most times they cannot be in the liquid form. The formulation of the anti-snake venom may be liquid or may be lyophilized powder. Now, it is only liquid if you are sure and very sure of the cold chain. That would do. But if you're not too sure of the cold chain, like in this our climb, the lyophilized powder would do. And now for the lyophilized powder, it usually comes in 10 mils, and you reconstitute first of all with 10 mils of normal saline or 5% dextrose water. And then when you reconstitute the lyophilized powder, you don't shake vigorously. You just swill it gently until everything is dissolved, and then you now transfer into larger volume of normal saline or dextrose water, depending on the one that is being used. And the volume of normal saline and dextrose water you transfer to is at the volume of 5 to 10 ml per kilogram body weight. So what that means is that if it's a regular 70 kg adult, you'll be using like 350 to transfer the solution to 350 or up to like 700 mils of saline for the patient, and then you infuse over 1 hour. Now, remember we said that anti-snake venom carries a lot of potential adverse effects, and the adverse effects are divided into 3. You have the early reaction, you have the pyrogenic reaction, And then you have the late reaction, which you can call a serum sickness. Now, the early reaction can occur within 24 hours of IV administration, and it's characterized by cough, tachycardia, itching, headache, nausea, vomiting. Okay. Now, the incidence of this reaction varies between 3 to 54%, which is really huge. Okay. And you don't know who is going to react. So it's always important to have your resuscitative materials like your adrenaline already drawn by the side and your antihistamines ready. Okay. Now, the second adrenaline and antihistamine, they're used to manage these early reactions. Now, the second type of reaction is the pyrogenic reaction, which occurs between 1 to 2 hours after treatment, and is characterized by chills, shivering, fever, and even convulsions in children. Usually, this reaction responds to tepispongin and use of paracetamol as antipyretic. Then late reaction, you have the what you call serum sickness. It can occur between 5 to 24 days after treatment. So that's wide. And by then, patient probably might have left the hospital. So it's always good to educate them so that when such a thing occurs, they know to come back for treatment. Now, it's usually characterized by urticaria, itching, arthralgia, periarticular swellings, proteinuria, etc. It usually responds to antihistamines. These late reactions, it responds to antihistamines. But if the attack is really severe, the patient can receive short course of corticosteroids. Now, I'd like to mention here that for the neurotoxic um, symptoms, that's neurotoxic venom, is very important. Like I said before, if there's respiratory distress and then probably the diaphragm, that's the biggest muscle for respiration, is involved, then intubation and mechanical ventilation is the way to go. Now, LRPs, that cobra, they usually have a toxin that resembles the myasthenia gravis. And so in such a situation, such patients may also be given injection neostigmine together with glycopene or atropine. But you will prefer glycopene to atropine because glycopene doesn't cross the BBB, the blood-brain barrier. Okay, but atropine crosses it, and atropine can induce delirium because it crosses the BBB, the blood-brain barrier. But the glycopene will not cross it, so you prefer to use glycopene if you're going to give a patient neostigmine. Okay, to actually, and why are you giving the glycopene? You want to prevent the bradycardia that is induced by neostigmine. So that's why you would want to give either atropine or glycopene together with neostigmine. Okay, that's that. Okay, so let's continue. Supportive care. Usually, a supportive care in bite victims include things like administering tetanus toxoid or the anti-tetanus serum, then wound management. Manage the wound, clean the area, and of course, you use antibiotics. Remember, we said that inside the mouth of these snakes, you may have bacteria harbor there, so they will need antibiotics. So transfusion, of course, the transfusion will help to restore, because remember the hemotoxins will cause bleeding because the blood is not able to coagulate, not able to clot anymore, so there'll be bleeding. But transfusion of fresh whole blood or frozen plasma, whichever is necessary, or plasma platelet concentrates can be done to help reduce bleeding. Then respiratory support when is necessary. Then there are some complications of snake bite. First one is coagulopathy. Of course, the blood does not clot as it's supposed to. Then bleeding, local tissue damage. And this local tissue damage can lead to, you can even have necrosis, can be as bad as necrosis. Okay. Then respiratory paralysis, which occurs with the neurotoxins, the venoms that are neurotoxic. Now, tissue and organ complications like your acute kidney failure, and then compartment syndrome. Compartment syndrome is like having the muzzle, the pressure in the muzzle is so high that the vessels are so constricted that blood is not going. And once blood is not going to that area, supplying the area of the muscles, you have ischemia, you have necrosis, and then gangrene. And if it's not taken care of, it can lead to gangrene, okay? And then if it can lead to amputation. But then it's important to know that the type of surgery that is used to manage compartment syndrome is what you call fasciotomy. But the WHO doesn't recommend doing fasciotomy immediately Okay. Unless you're sure that the bleeding has been stopped, that anti-snake venom has been administered, and then the patient is no longer bleeding, that coagulopathy is already taken care of before you talk of fasciotomy. Okay. So infection is a complication, including shock and serum sickness. Then the roles of the pharmacist. Now, it's important as pharmacists, first and foremost, apart from our clinical functions, we also have the function of making sure that the important vital essential medications are available. Like we need to stock the anti-snake venom, procure and then manage the stock. Probably have a relationship with the company or other sister hospitals who use it more so that they don't expire on us. Okay. But in my center, we always procure and keep, even if they expire, we still procure because you never can tell who will need it. And we had reasons to, even in the middle of the night, use it. Other hospitals nearby come to get from us. Okay. Now, anti-venom preparation and dispensing, we should know how it's done. Remember how I talked about using 10 mils of normal saline or dextrose, 5% dextrose water to reconstitute the lyophilized powder. You don't shake vigorously. You swill. You just swill it gently until it's dissolved before you transfer to larger volume for infusion. Okay. Now you monitor for adverse drug reactions, very important, and have your anaphylactic packs ready. Like you're ready, you have your adrenaline. And the adrenaline that is used the 1 to 1,000 formulation, and the dosing for adults is administered at 0.5 milligram intramuscularly. But for children, I think it's about 0.01 um, milligram per kilogram body weight. Now, the role of the pharmacist is also to provide drug information and toxicology information, data collection and surveillance, and then, of course, research is also part of what we do as pharmacists. Now, let's look at the case study quickly. Now, this is a patient AM, female, 30-year-old housewife who resides at Doma. Then what was her complaint? She presented to the A&E with a complaint of snake bite on the dorsum of the left foot, 6 hours prior to the presentation. Now, there was bleeding from the bite site, which of course tells you that this is a hemotoxic type of venom. Now, patient had also vomited blood. Remember we talked about vomiting is one of the systemic signs of envenomation. Now, patient history, okay, she is not a known diabetic, does not smoke or drink alcohol, not hypertensive, no known food or drug allergy, which is important for us to know. And then she presented at the facility at Lafayette, Federal University Teaching Hospital. Yeah, okay. Now, on physical examination, she was found to be pale. Remember, this patient has been bleeding from that site. Then anicteric and febrile, okay? So she had dark red blood on the gum and lips. Now, this is one of the signs of hemotoxic venom. It gives you gingival hemorrhage, okay? So the gums will be bleeding. So she dark red blood on her gums and lips. There was no sign. It's not as if she bit her tongue. Just to show you that she had a systemic envenomation by hemotoxic venom. Now, she had edema on the lower left limb with presence of fang marks. Now, absence of fang marks does not mean that it's not a venomous snake. It just means that the snake doesn't have fangs. Okay. Now, there was bleeding from the bite site. Were her vitals? In the cardiovascular system, her pulse rate was 88, which was still within normal. Her BP was 170, basically within normal, based on what? Then her heart sound, both 1 and 2 were heard. Then her abdomen was flat and it was moving with respiration. There was no tenderness, no organomegaly, meaning that her liver, kidney, spleen were all normal size. Then active bowel sound, which is a good sign, to be sure that there's nothing like a paralytic ileus, which is okay. So active bowel sound, respiratory rate was 16 cycles per minute, which is within normal range, and her oxygen saturation was quite optimal, showing that patient was getting in enough oxygen, and then the end organs were receiving enough oxygen. Then chest was clear. Now the investigations were ordered, and they include the packed cell volume, the electrolyte, urea, creatinine, liver function test, full blood count, plus the differentials, and of course the 20-minute whole blood clotting tests. Okay. Now these were her results. Okay. So the sodium was within range. Basically, everything here was within normal range. Okay, nothing was deranged. Although the potassium and the sodium was just low normal. Okay, and then potassium was just slightly low normal. It's okay. Everything here is okay. Then the liver function test, everything here is okay except the patient's total protein, which is not too okay and may not really be associated with the bite, or might have been some underlying issue, or probably also maybe associated with the bite, maybe because of the leaking of the dermatous condition on the lower limb, okay, and then the leaking of protein and other toxins in the uh, swollen limb, okay. So the packed cell volume was okay, everything okay, except the neutrophils. Remember we said that neutrophilia is a sign of envenomation, systemic envenomation. So she had her neutrophils elevated slightly, not too high, but they were elevated actually. Okay, so the diagnosis of snake bite with systemic hemotoxicity was made. And so patient was had anti-snake venom administered. Okay. And then the clotting time was to be repeated after 6 hours. And if it was still deranged, the anti-snake venom was supposed to be repeated. Now she was given tetanus toxoid, given ceftriaxone, metronidazole, paracetamol, and then her vitals were monitored closely, which is very important. Now, this is a chart showing her results and the different days. Now, the first day, which was the day she presented on 20th, you see the 20-minute white blood cell um, coagulation clotting test was greater than 20 minutes, okay? So it was positive, showing that she had a envenomation by hemotoxic type of venom. Now, the patient received IV anti-snake venom, 2 vials at 6 hours intervals. Okay. Now, the brand I was giving is the one you call Veins. And this Veins brand contains 4 different snake venom from cobra, and then 2 different types of viper and crate. Okay. Then by 21st, her pulse rate had increased, showing tachycardia, and then her BP had dropped, okay, showing some form of shock occurring, and then the 20-minute clotting, whole blood clotting test was still positive. So they gave her a different brand, Equitab. Equitab actually contains those 3 major venomous snakes that are seen in Nigeria. It contains anti-snake venom to them. That's the carpet viper, the puff adder, and the cobra. So this Equitab contains the anti-snake venom to venom from these 3 different types of venomous snakes. So she received that 1 vial, and then of course they were still giving her normal saline alternate with dextrose saline 1 liter 12 hourly. Now by 22nd, the next day, she still had tachycardia. Her BP had dropped more. She now had shock. So all IV medications were discontinued, and then of course normal saline was given because you see her BP had dropped to 79/73, and that's really shock. And then they changed the IV antibiotics to oral, okay, and added a pain medication. But then her 20-minute whole blood clotting test had dropped to 30 minutes, so showing that it was returning to normal. Okay. Now by 25th, on the 4th day, her BP had stabilized, pulse rate had gone back to normal, and then they just continued. And the patient was transfused with 1 pint of fresh whole blood, because fresh whole blood contains platelets. Okay, so they transfused that. Now, by 29th, it was the 20-minute whole blood clotting test was now less than 10 minutes. Okay, and patient was on levofloxacin and cocodamol. Now, let's look at the drug therapy problem from what we're seeing. So the first one is what use wrong drug. Now, the patient was given tetanus toxoid, and not, but ideally, what she should have received was anti-tetanus serum. Now, tetanus toxoid helps to prevent, it gives active immunity, but the system has to form the antibodies. So it's like for future. Like the anti-tetanus serum, which already contains the antibodies. Anti-tetanus serum is gotten from the equine horses, where the venom is put in horses, and then they form the antibodies extracted and purified, and it's not venom now. The toxoid is another horses, to get the anti-tetanus serum. But the human tetanus immunoglobulin, that one is gotten from the human being. But the anti-tetanus serum has a equine background, that's from horses. So, but both of them are for passive immunization, immunity, and then they help in treatment. So the patient, we don't know her history, whether she has ever taken before. So anti-tetanus serum should have potential one. Remember we said anti-snake late reaction that can occur up to 2 was advised to refer back to the facility if any such experience occurred. Then wrong drug. This is a female patient in childbearing age. You wouldn't want diclofenac, misoprostol. You want a different, a safer pain medication for her. And of course, it was accepted and it was changed to paracetamol. Now, there's possibly another additional drug, metronidazole, but the person wasn't stepped down to any oral metronidazole, so she could have, that was supposed to have been added. Then, if you are talking antimicrobial stewardship now, which why I put probable drug therapy problem is that it may not really be so. This one depends on the institution. Now, if the institution's antibiogram is such that levofloxacin, it was suffices in their area, this patient was supposed to have gotten either penicillins, or if the patient reacts, erythromycin. That's what is required, okay, for such snake bites. But they jumped to levofloxacin, which is a watch antibiotic. So this is something to look at. It may not be totally wrong, like I said, based on the antibiogram of the hospital. Now, this patient was discharged on 29th of, and then she really significantly improved. The bleeding had stopped. Remember, there was bleeding from the bite site. And then she returned home after 9 days of hospitalization. Now, prevention is key, and there are key things we can do to prevent it. The grasses around the house should be cut short. Clutters should be removed. Don't have things packed, very close to the house. You have a place where you pack things, because snakes love such places. They'll just go and hide because they are cold-blooded, so they can't regulate their body temperature. Now, you listen to cues from domestic animals, because some domestic animals may start shouting when such venomous snakes come in. Then keep rodents away from the house. Don't go out in the night without light. Always have your torchlight. Very important. And do not have tree branches touching the house. Very important, because they can crawl from the tree branch and enter the house. Now, clear any possible hideouts of snakes. Environmental awareness is important. Then use of protective clothing, particularly farmers that work, maybe that harvest rice, because there are some snakes that stay in such swampy areas, so they should wear as well. Okay. Now, you're not supposed to. Snake bite is really a public health concern, and then there's the importance of public health education is can't overemphasize it. It's very important. People should be educated, and then there should be improved models, because data will help us project for the future and know where we're not doing too well, and know what to do to really take care of such incidents coming up. And then the data will also help areas where you have the highest occurrence of snake bites, and the seasons when you have the highest occurrence, centers where you have challenges, and then you know how to wade in and solve the problem. Now, training on proper antivenom handling and cold chain is standard and should be encouraged. Thank you very much.
Thank you so much. Thank you so much. Thank you so much. Fam Ola, you've actually done a very powerful presentation, and this is so rich and educative. Thank you so much. Thank you everyone for for giving out your time to listen. And this has been a very serious matter nationally as worldwide in Nigeria and locally within where we're staying. And as we've been told and informed, and as we've seen the clinical judgment that has been made, I believe that a lot of us within our healthcare facilities, within our society, our environment, we may have one or two found this kind of cases. And I think I have learned a lot, so much today as regarding this topic of snake envenomation. Thank you very much. Really appreciate this. Once again, thank you everybody for being part of this. And I think without wasting much time, we want to take inputs, questions as regarding this, because I know these have come up and one or two want to ask questions, want to make inputs as regarding some statement that has been made. So please, if you have questions, you can notify and we'll give you room to ask your questions. And I believe we are here to tackle such issues and see how the healthcare system, pharmacists play a very good role in the healthcare system. So please, if you have any question or any comments or input you want to make, please, you can notify and such opportunity will be given to you. Thank you. All right, Folasade from Folasade Lawal, I think you are the first person who notified. If you have a question or a comment, please, over to you.
Good evening, distinguished colleagues. Thank you very much for the very enlightening presentation and detailed too. Lots of learnings. I appreciate the prevention that was emphasized. Thank you. So I want to comment a bit on the drug therapy problems. I just think that the choice of NSAID at all should not have been because of the bleeding bouts that this patient had, apart from the misoprostol. My thoughts are maybe wrong. I think that's also part of the drug therapy problem. Then another challenge we have generally is getting this vaccine. I run a community pharmacy, and I know that right now it's difficult for us to get. Formerly, we've stocked them, even though, interestingly, we never sold any. As per, they would always have expired before the need. So we would, I remember one or two times we had to give it out like that because they didn't have any option and they used and the patient recovered. But we didn't sell, we couldn't sell because it was expired. I also know that when I was in school, when we were in Ife, one of my friends had a snake bite like that, and the anti-snake venom had expired for 9 months. While they were debating, she was already going unconscious and all that, but eventually used it and she recovered. But the important thing is, where can we get this anti-snake venom? Uh, um, and then what other roles as community pharmacists can we play? Thank you. God bless you.
All right, thank you so
Okay,
much.
am I meant to answer or will take other?
Yes, you are. You can answer.
Oh, okay. Thank you very much. Okay, thank you, Ma. Thank you very much for pointing out. Yeah, you're right about the NSAIDs, the bleeding and all that. Okay, so it should also be part of it. Now, for where it can be gotten, I'm not directly involved in procurement at my center, but I know we usually get it. I'm not too sure where, so I can't really answer that now. So if someone else knows, the person can let us know. Okay, that's that. Then as community pharmacists, I believe in community pharmacies like the word is the community. You have the community there. A lot of people come in there. Now, is for you to have an idea of probably, apart from being able to stock it, have an idea of other hospitals that may have it, like networking. Because there may be a hospital that has it and is seated there, is not being used and nobody knows, and then is needed and everybody's running up and down. So is in networking is important, both amongst the community pharmacists and then amongst the community pharmacists and the hospitals within the environment where they are. And then as community pharmacists too, they are public health personnel too, to educate people, okay, on how to avoid such snake bites and what to do when it occurs. So I think as community pharmacists, we have a lot of roles to play. Thank you.
Thank you.
All right. Thank you very much. And thank you for that wonderful input and the fallback to our pharmacists who gave us a powerful presentation. And as regarding where to get some of these things, I think a lot of people may have one or two to say, but I believe Plateau State, just precisely around Zamko, where they have a lot of snake issues within that terrain, they mostly have such anti-snake venom. So within ourselves pharmacies, we can actually link up to see how we can assess this thing for better and quality healthcare as related to this. Thank you very much. All right. Our next person who have indicated, Ekedagwa Ape, please over to you.
All right, thank you very much. My name is pharmacist Ekedegwa Daniel Ape. I practice at Federal Medical Center, Asaba, South Nigeria. I want to commend the presenter for a very wonderful job. I work as the head of Medicines Information and Poison Center of FMC Asaba. The contribution I have to make is this. First and foremost, the MIC, in collaboration with the Accident and Emergency Pharmacy, if it's available in the hospital, should have information about the kind of snakes that are predominant in the area of practice. This is because Nigeria has a very wide terrain. Some of us in the south here, the kind of snake we are likely to encounter may be different from the grasslands in the middle belt, and when you go further into the northern part of the country towards the Sahel region, because of the low level of rainfall there, the venom, the concentration of the venom and so on and so forth, they change. So that means that we need and the varieties of snakes also change too. So that's what we need to stock. They vary by regions and by location. So I think it is the duty of the MIC to have that information ready. Why do we need it ready? Because snake venoms, anti-snake venoms are not cheap. They are very expensive, and the use don't come often. Sometimes they may be seasonal. So whenever it is being stocked, the information is also available with the MIC or the A&E pharmacy, especially for major hospitals in that region, so that the information is also adequately disseminated, so that in the community and around, they should know that this is available. Sometimes when our people get bitten by snakes, they may rush to the primary health care centers, which may not be adequately positioned to treat. So, but if these informations are available with networking, like other speakers have said, we'll be able to coordinate this information, and with also the pattern, we know, okay, we have, say, an average of so kind of bites per period, and maybe spikes are period. So with those kind of information, we will be able to put them together and know how to prepare adequately. It's actually a public health concern, so we should not leave it for just one hospital. If we expect every hospital to be adequately prepared, we won't be able to get anywhere. And as pharmacists, we are at the forefront, because with procurement, we are the ones that should make it available. So I think with that, we should be able to combat this snake envenomation. Then lastly, before I go, I think I heard the speaker spoke about ATS and TT. Toxoid is actually a weakened form of the bacteria or whatever that causes that tetanus. So it is not actually, it's not the source. What matters there is the either a weakened portion of it that will stimulate immunity for future use as the toxoid, which usually is given in very small dose like 0.5 mil. So just something to stimulate your system to build up the immunity. But the anti-tetanus serum, the serum is the one that they engineer either by cloning, by recombinant DNA, or by equine or bovine source, either the horse or the cow. They can use to prepare to envenomate with tetanus and collect the this and purify. Those ones come with a lot of issues with the protein reaction to certain protein fractions are not properly purified. So I just want to just contribute a little to that aspect. Thank you very much. Once more, it's a very bright and beautiful presentation, and I have learned a lot from it. Thank you so much, Sipan Nasarawa State.
Thank you very much, Pharmacist Ape, for this wonderful enlightenment as well. Thank you for making great inputs to this topic. We are really blessed tonight. I think the last person who have actually picked interest for comment, Pharmacist, I think the name here is DAE. Please, over to you.
All right. Thank you very much. Good evening, colleagues. Thank you for this opportunity given to me. Thank you to the presenter for such a beautiful presentation. It's quite enlightening. What I just wanted to find out, I don't know, all those the tachycardia, the increased pulse, and then the blood pressure going lower than normal. Yes, suspected case of a shock. I just want to know, was there any medication specifically given in this or for these conditions, or with time as treatment went on, these parameters got better? That's just my question.
Oh, okay. So, yeah, the shock, of course, is really the first way to manage shock is to resuscitate using normal saline. So if you resuscitate using normal saline and it still is not okay, that's when you now start talking of your vasopressor, like your noradrenaline. But this patient responded to normal saline. And of course, remember, she received the anti-snake venom because all these things are signs of systemic envenomation. So once the anti-snake venom worked and kicked in, the vitals had to return to normal because a causative factor, which is the venom, the hemotoxic venom, had been taken care of, had been neutralized by the anti-snake venom. So basically, she received normal saline to take care of the shock. Okay, immediate taking care of the shock, and it worked. Had it been, it didn't work, and it's patient because you can't keep giving fluid, because if you keep giving fluid, you have fluid overload. So if you give fluid and to a certain level and it doesn't respond, that's when you now talk of your vasopressors. But patient responded, and then of course the anti-snake venom, which is the antidote, which is the main thing that took care of the systemic envenomation. I hope I've been able to answer the question. Thank you.
Yeah, sure. Thank you very much. Yeah.
All right. Thank you so much for this answer to this question. Very clear and prompt. And I think our own chairperson, Dr. Maureen Wafo, you are welcome, ma.
Welcome. Okay.
Good
Good
evening.
evening, everyone. Hope I'm
Good
audible.
evening.
Okay. I want to start by congratulating Nasarawa State for making it free time. We've been on them to make this presentation. To God be the glory. Today we are here listening to this wonderful presentation. Despite all this, the presenter had emergency also to go into an interior area where he may not have access to network. But we insisted that this good topic must be presented to us tonight. As God will have it, He gave us His slide, and I say yes. Once it's on toxicology, I know an expert in toxicology, which is our dear Dr. Ola Omaka. You people can bear with me that she's really an expert in this. She had a master's degree in pharmacology and toxicology, and she did the useful tonight. So, my dear Dr. Ola, thank you so much for this great exposition tonight. And also, I want to thank our moderator. During the course of the presentation, I started this our well-renowned pharmacist on this call. Professor Valodi is still here with us. Prof is the chairman of clinical pharmacy faculty of our WAPCP. We are always happy to have you on this call every Friday. Thank you so much. Our dear pharmacist Folasade Lawal, always here with us, and we are glad to have you. My boss, retired but not tired, pharmacist Waneka Mashoma, I'm happy to see you. Our dear Professor Sunday Owofisayo, you've been talking all the way throughout on our platform tonight concerning the new, can I say, petition from our dear brothers in the other profession. And you can see that what you've been saying is the reality. Pharmacists need to, know our game so that other healthcare professionals cannot look down on us. Thank you for joining us. I started my dear colleague Okonkwo and all the way from UK. Thank you so much for joining us. I will never forget my dear Secretary General, Dr. Isa. Thank you so much. And our dear Finance Officer, Dr. Jaziro Mayemel. I'm happy to have all of you tonight. Wow, it was a great exposition. I learned a lot. Earlier, I thought we must have to use tourniquet in all bites. Like tonight, I already know that you don't need to do that when the snake bites. I learned you do not cut or even suck or even apply ice. Okay, so many tips that I learned tonight. Even that the dose of the antivenom should still be the same for both adults and children. So I pity those who didn't join us tonight. I just have a few questions or so. How do we identify the type of snake bite, or let me say the type of bite? Sometimes at the community level, patients don't really know what really happened. They knew that something bit them. They don't even know whether it's a scorpion or a snake. How are we going to differentiate to identify the type of bite before we now talk of the other measures to help such patients? Okay, and how do we determine the dry bites? So, my dear presenter, can throw more light.
Oh,
Thank you so much.
okay. So, the as per knowing the species, okay, the one that is really, really, really well known that everybody can identify very well is when you see a cobra, you know this is a cobra because of the way he brings up his head and then the way the shape of the head is. Now, but to identify the type, to know whether it's a snake bite, to differentiate it from snake and scorpion and all that, for venomous snakes that have fangs, you see the two fang marks on the limb. Now, some venomous snakes don't have fangs like some vipers. You just see a row of teeth, like a point of bite. And now, if it's a venomous snake that has hemotoxic venom, the bite side, the wound will be bleeding. Now, if it's a venomous snake that is neurotoxic, you can have signs like ptosis. That's the eyelid, the upper eyelid will drop and cover the eye. The person won't be able to control opening the eye, as if it's like you have in myasthenia gravis that has that is showing the our ophthalmic signs of myasthenia gravis. Now, as per knowing the species, you may not be able to, as a layman or a layperson, may not be able to tell. But in some communities, for instance, in Nsukka, where I UNN, we had this the one they call Echieteka in Igbo dialect. As in like tomorrow is too far because it's highly poisonous, and I think that's a viper. Okay, so there's a carpet viper. It's a tiny black snake that it's not big, too big. It's just slim and all that. So it depend like the speaker from someone from FMC, as I was saying, you should be able to know the area. What will help you determine the species, what the species that are prevalent in a particular area, and then if research is able to tell us that this is um when they usually bite is more, and then this is species that is prevalent. But by and large, you may not be able to tell. Okay, so but the signs and symptoms can tell you if it's hemotoxic venom or the is neurotoxic. The kind of manifestations you see can tell you, but you may not be able to pin the species except is a person really knows and is an expert in identifying those snakes. Then dry bite. Now, with dry bites, you can't have systemic envenomation. You only have the local effect, like just pain at that site and then maybe slight swelling. That's what you have. But you won't have any systemic effect. You won't have the tachycardia, the hypotension, the bleeding from the site. You won't have that. It will just be a local thing contained there because of it beats the person, but it didn't transfer any venom. So it will just you only have just the local effect, slight swelling at that area, and then pain. That's all. That's how you know it's a dry bite. And it's been known that even those venomous snakes, uh, uh, um, 70 something percent of the time, or 50, I think 50 something percent of the time, is dry bites that they give. Remember that these animals bite out of because they are trying to protect themselves. It's not as if they really want to bite, but because they want to protect themselves or they feel they are in danger. Okay. So I hope I've been able to answer the question. Thank you.
Thank you.
All right. Oh, thank you very much for the wonderful attempts to these questions. I myself actually have learned a lot as regarding this snake envenomation and across the bit of all pharmaceutical aspects. And I believe that as pharmacists, we can use our clinical skills, play our role judiciously, and I think with access to anti-snake venom within our healthcare facility, be it the community pharmacy, be it those in the hospital, it will go a long way to have saved life, and it will go a long way of help bringing interventions as towards management and treatment of such cases. So I really learned, and I believe everyone here have one or two that he has learned. But I believe because of time factor, I think we've exhausted all our comments and questions because all have been exhausted from the table. So thank you
Let me
very much.
make
Once
a
again,
comment.
I really appreciate. I really appreciate the leadership of SIPAN for giving us this opportunity to, as a platform, to sharpen our clinical skills in presentations, to enable us participate, join, and learn upgrades. I call it an upgrade timing. Within every week, we have, in one way or the other, have presentation to join. Thank you very much for this innovation, and we believe that pharmacists within the wider world, SIPAN is here to stay, and SIPAN has been where we have also learned a lot of things. Thank you very much, and thank you so much. So I believe
Sorry, Emily,
for our present.
sorry, Emily, before you close us, please, I want to appreciate the man behind the thing every Friday, making sure that our clinical meeting goes on without any hitches. No other person than Dr. Ibrahim Bello. sir, we appreciate your effort. God bless you. You are a gift to SIPAN. Continue doing the good work. Thank you so much. We appreciate you always. Can continue.
All right. Thank you so much. I wanted to give you time to say something, ma. After I've spoken, but no problem, ma. So, ma, please, I think this time for you, our chairperson of SIPAN, is an opportunity for you
I've
to
spoken a
greet
lot.
us.
I want to
Actually,
allow my dear Secretary General, Dr. Issa, to give us a closing remark. Thank you.
all right.
Good evening, everyone. On behalf of
Okay.
the chairman and members of the National Executive Committee, as well as the council and entire members of the Clinical Pharmacists Association of Nigeria, we want to most sincerely thank the presenter and moderator of tonight's event, including the scheduled speaker who was unavoidably absent. We thank you very much for the knowledge imparted, and we do hope that we'll all put them into practice. We also thank everyone that came and was present from beginning to the end of this session. We promise to give you better and improved programs as we enter into the next year. Thank you very much, everyone, and do have a very beautiful night rest.
Thank you so much. Thank you, everybody. Thank you once again for joining. We have our professors in the house, fellows in the house, our leaders in the house, cut across every sector of pharmacy. We have consultants, we have clinical pharmacists, consultant clinical pharmacists in the house. Thank you so much for joining tonight. It's a wonderful moment of learning. We really appreciate and thank you so much. Without any waste of time, we want somebody to just round this with a word of prayer for us, and we'll say goodbye. Can somebody just lead us with a word of prayer? Okay, pharmacist Ibrahim Bello, please can you just lead us with a word of prayer?
In the name of Allah, the most gracious, the most merciful, we give thanks to God Almighty for the blessing that we had tonight and for this beautiful and impactful lecture that we have received. We pray to God Almighty to make it make it beneficial to us and to humanity in general. Amen. Subhana Rabbika, Rabbil Izzati Amma Yasifun. Prayer over. Thank you.
Amen. Thank you.
Amen.
Amen.
Thank you
Thank
so
you.
much.
Good
Please,
night.
good night. Thank you.
Amen.